Good afternoon, everyone. My name is Anne-Mary Phillip from the Integrated Care Resource Center. We're a couple of minutes past 1, but we're going to go ahead and begin. Thank you for joining us today. Our study hall call today is on state use of Medicare Advantage encounter data, perspectives from 2 states. So the 2 states that will be featured on today's call include Arizona and Tennessee. We will have representatives from both states present approaches to obtaining and using Medicare Advantage encounter data, including contract requirements, uses of the data for care coordination, and the state resources that were needed to make effective use of the data. Jim Verdier from the Integrated Care Resource Center will begin with a brief overview of how states can use Medicare Advantage encounter data before he'll turn it over to Patty Killingsworth from Tennessee and Lori Petrie and Kiana Wright from Arizona. Jim from the Integrated Care Resource Center will moderate a panel discussion with our featured speakers who will share background on their state's DSNP programs and answer a series of questions about how they obtain and use Medicare Advantage encounter data on Medicare services used by dually eligible beneficiaries enrolled in those programs. So this slide just covers an overview of what will be presented today. Like I said, Jim will provide the overview, and then we'll switch on over to our featured speakers from Arizona and Tennessee and the moderated panel discussion of today's session. We are so pleased to have them join us and hope that this study hall call is useful for states looking to access and use Medicare Advantage encounter data to further Medicare-Medicaid integration efforts. Our panelists have already stated that this sort of training would have been valuable when they were designing their programs, so we really hope this is useful for your state's Medicare and Medicaid integration efforts. So at this time, I am just going to take a moment to unmute all of the lines.
You are no longer muted.
Just today. And we do have all
You are no longer muted
to the call today, so please bear with me as we go through the roll call. Do we have anyone from Alabama on the line? Alaska? Arizona?
Yes.
Arkansas?
Yes, yes.
Thank you, I got Arkansas. Is California on the line? Colorado? Connecticut? Delaware? Florida?
Yes.
Thank you. Georgia? Hawaii? Idaho?
Yes.
Thank you, Idaho. Illinois? Indiana? Iowa? Kansas? Kentucky? Louisiana? Maine? Maryland? Massachusetts?
Yes.
Hi, Massachusetts. Michigan?
Right here.
Thank you. Minnesota?
Yes.
Mississippi? Missouri? Montana? Nebraska? Nevada? New Hampshire? New Jersey? New Mexico? New York? North Carolina? North Dakota? Ohio?
Here.
Hi, Ohio. Oklahoma? Oregon?
Yes.
Oh, hi, Oregon. Is there someone from Pennsylvania on the line?
Yes.
Hello. Rhode
Hello.
Island?
Yes, Rhode Island's here.
Thank you. South Carolina? South Dakota? Tennessee?
Yes.
Hello. Okay. Texas? Utah? Vermont? Virginia?
Yes. Yes.
Thank you. Washington? West Virginia?
Yes.
Thank you. Wisconsin? And last but not least, Wyoming. Okay, has anyone else joined us since we've begun the roll call? If your state has not already introduced themselves, you can feel free to let me know now. Okay, so we're going to go back to muting all the lines. Phone lines will remain muted for the remainder of the presentation in order to eliminate background noise. We will have a Q&A session at the end of.
You are now muted.
If you'd like to submit a question, you may do so using the Q&A feature. There is a Q&A icon in the drop-down menu of the toolbar at the top of your screen, and this slide just gives a screenshot of what that toolbar looks like. We will be recording this call, so your state colleagues who are unable to join will be able to listen into the recording at a later date. Okay, thank you all for bearing with me through the logistics and the introductions. I'm pleased to now hand it over to Jim Verdier to begin today's presentation.
Okay, thank you very much, Anne-Mary. Let's just go to the next slide, and I can give a brief overview of encounter data and the Medicare Advantage and Medicaid encounter data. So what are encounter data? They're simply data on services provided to enrollees in capitated managed care plans. They're roughly equivalent to the claims data that state Medicaid programs get in the fee-for-service system. They may contain somewhat less detail, fewer edits, things of that sort, and they may not always include the amount that the plan pays to providers for the service. That really depends on what a state specifies in their Medicaid program. Most states with capitated managed care programs in Medicaid have required health plans to report encounter data to the state for many years. The quality and completeness and the actual use that states make of the Medicaid encounter data varies a lot. My colleagues at Mathematica have done extensive work on Medicaid encounter data over the last several years, and you see sites to the various documents that have been prepared and links to those documents. And so any of you who need information on state-by-state variation in the completeness and quality of encounter data and other related issues can go to those documents and find out most of what you need to know. Next slide, please. The availability of Medicare Advantage encounter data. CMS did not require Medicare Advantage plans to submit encounter data until calendar year 2012. They were required to submit encounter data for services provided in that calendar year. So the actual encounter data came into CMS subsequent to that calendar year 2012. Before 2012, most Medicare Advantage plans did in fact collect encounter data for their own use, but were not required to report the data externally or to use any sort of standardized formats. The Medicare Advantage encounter data for calendar year 2012 and later years is not publicly available yet, but we anticipate that at some point it will be. Next slide, please. So what are the uses that states have been making and could make of Medicare Advantage encounter data? We looked at the so-called MIPA DSNP contracts for a dozen states for a TA brief that ICRC did earlier this year, and in those contracts, 10 of the 12 states required DSNPs to submit their Medicare encounter data to the state, and you see the list of the states there that do that. States that contract with Medicare Medicaid plans in the CMS financial alignment demonstrations can also obtain Medicare Advantage encounter data either through a CMS contractor or directly from the MMPs, but we're not going to be going into that issue in this webinar. We may get it in a later webinar. So the next slide will bring us to an overview of the Arizona and Tennessee DSNP programs. So you have that information for background, and the folks from Arizona and Tennessee will briefly describe their programs, and then we'll jump into the moderated discussion.
Sounds great. Thank you, Jim. This is Kiana Wright, and I serve as the Medicare Specialist for Access here in the state of Arizona. And I'm the primary point of contact for all of our D-SNP plans. And I manage the MIPA contracting process, and I interface with MMCO and other stakeholders. So my current project, that we won't go into detail at all here, is the lead for our integration efforts of the general mental health and substance abuse services for the dual population, and that's going to be effective 10/1 of this year. But just as an overview of our program, all plans that have a contract with our state are required to offer a companion D-SNP product. So, for example, we have several service areas in the state. If one is awarded a Medicaid contract in one service area, they're also required to hold a Medicare contract in that same service area, and that's how we can promote alignment. The Medicaid managed care enrollment is mandatory. We only have one exception to that. All of our Medicaid plans are managed care and have been since the onset of our program. The only exception, as I mentioned, is our Native American population. That we do have a very small, about 7,000 duals in this Native American population that are a fee-for-service. And our access acute, so we have our long-term care as one bucket, and the acute is those individuals not needing long-term care. So they're kind of separated in our system just from those distinctions. But the acute Medicaid plans cover all the primary care, acute care, including drugs, and the coverage of the behavioral health is currently delivered by our REBAs, which is our Regional Behavioral Health Authorities. And as I mentioned in my introduction, that's going to be integrated beginning in October of this year. For the long-term care side of the house, our Medicaid plans cover all of the Medicaid benefits, including behavioral health. And those are, the long-term care services are for those requiring a nursing facility level of care. And we have a lot to talk about on the long-term care side that I also won't get into, but we also do a lot of home and community-based placements instead of a lot of institutional placements, and we're really proud of that. And our long-term care services have been managed care since 1989. So we have about 76,000 D-SNP enrollees as of April 2015. And of those individuals, about 81% of them are aligned, which essentially is they are enrolled in the same plan for their Medicaid services as they are for their Medicare services. And that's through that companion D-SNP.
This is Patty Killingsworth. I'm with the state of Tennessee, and I'm the Chief of Long-Term Services and Supports in the TennCare program. I am joined by my Deputy of Quality Administration, Michelle Moore-Jernigan, and her Assistant Deputy, Rachel Turner, both of whom work in the Long-Term Services and Supports programs and with the D-SNP program. While we are not, I guess, technically a Medicare division, we tend to do a lot of the day-to-day work with our D-SNP plans because such a significant portion of people who receive long-term services and supports are in fact dual eligible, and the most significant component of Medicaid expenditures for the dual eligible population really are the long-term services and supports benefits. So we share responsibility for the D-SNP contracts with our Office of Managed Care Contracts and Compliance. In many respects, the state of Tennessee is like the state of Arizona, and in some other respects, we want to be like the state of Arizona, particularly as it relates to the management of D-SNPs. We have not been at it quite as long as they have with respect to the D-SNP alignment and program. Like Arizona, our Medicaid program is entirely managed care, and we don't have any exceptions to that particular requirement. So all of our Medicaid services, including physical health, behavioral health, long-term services, and supports for seniors and adults with physical disabilities are delivered through the managed care program. We do not have a requirement currently that all of our, that every single D-SNP is also a Medicaid health plan, but we did begin in 2015 to require all of our Medicaid managed care plans to have a companion D-SNP in every county of the state where they operate, and we moved to statewide implementation in 2015. So at that point, we're really beginning to focus on statewide alignment wherever possible for the dual eligible population. If the plans were not statewide at contract award and we went through a procurement process in late 2013 for the 2015 implementation, then they're required to move towards statewide coverage in their D-SNP contracting as expeditiously as possible, and really to hopefully get there by 2016. We currently have 2 of the Medicaid MCOs that are also statewide with their D-SNPs, and 1 who has a few additional counties to try to pick up in 2016. We do have a few existing D-SNPs that are not also Medicaid managed plans. They did not win the procurement process, but at the present time we do continue to allow those D-SNPs to operate. We won't be contracting with any new D-SNPs as we're really working toward alignment of the population. We have about 70,000 D-SNP enrollees as of April 2015. About 50,000 of those are full benefit dual eligibles, where we really could get to full alignment across both programs. And out of that, 61% actually are in aligned companion D-SNPs and Medicaid plans for services across both programs. That's a 30% increase in alignment over about the past 16 months as we focused on a number of different strategies to really increase alignment, not the least of which were efforts in our reassignment process for Medicaid statewide contracts to really focus on reassignment wherever we could achieve alignment between the Medicaid plan and a D-SNP in which the member was already enrolled. And to continue those efforts, we are working with our health plans to begin seamless conversion of their members as they attain Medicare eligibility, with one of the plans already having approval to begin that in June of this year. Turning to the next slide and really looking at our contract requirements, here Arizona and Tennessee are very much the same, although the language in our contracts is different. Essentially, we apply the same requirements to Medicare Advantage encounter data that we apply to our Medicaid contracts. We expect that all of our health plans are submitting that encounter data. It has to have all of the same elements as does our Medicaid encounter data, including payment information, and it has to pass all of the same edits that our Medicaid encounter data has to pass. And with that, Jim, I think I'm turning it back to you for the discussion.
Okay, thank you very much, Patty. Let's go to the next slide, which is just the title slide. And so let's go to the next one after that. Just to provide a little bit of additional background, could the folks in both Arizona and Tennessee say a little bit about how long you've been requiring D-SNPs to submit Medicare Advantage encounter data? And as context for that, how long have you been requiring the Medicaid managed care plans to submit encounter data? Because that's the groundwork for what you're now requiring the D-SNPs to do.
So I'll go ahead and start. This is Lori Petrie with the state of Arizona. I'm just as a brief introduction, I'm the data analysis and research manager. I'm in the same division as Keanu, but I'm responsible for all things encounter as well as all system interfaces with our MCOs. So just starting with how long we've been requiring the MA encounter data from our health plans, that has been in place now for several years. We have a data exchange process we call our blind spots that was a critical element of. How long have we been requiring Medicaid encounters? Pretty much since day one. The Access Program was started on 10/1 of 1982. We've always been managed care, and so we've always had some form of encounter data, and over the years we've tried to employ continuous improvement of that. As far as significant differences between the two, I would say we try and keep them as consistent as possible. We try and integrate that data. We try and have it be part of the whole picture. The one place where we're still working through a few gaps in the data is we do get Medicare Part D data directly from CMS, and we've been kind of working to get as robust data elements out of that data as we're sometimes able to get directly from our MCOs. So just a kind of a work in progress, and we're making a lot of improvements in that area, hopefully. And then the main use, again, is for that overall picture of the member, our blind spots data, for lack of a better term. We do have contracts, and we'll talk about that later, I believe, in another slide, requirements where our MCOs need to use that data that's exchanged to make sure that there's care coordination and that we're looking at a variety of things for those members, identifying high cost, high need, et cetera. So, and I do know there's some other slides later where we'll get into that a little more.
This is Patty in Tennessee. We actually only began executing MIPA agreements or DSNP agreements with DSNPs in 2011. And in 2013, in those MIPA agreements began to require for the first time a full data interface with all of the DSNPs. And by full data interface, I mean the ability to exchange eligibility information as well as encounter information, divided into 3 separate phases. Phase 1 was really the eligibility enrollment interface, where we began to provide the DSNPs with information about Medicaid health plan assignment, and to provide the Medicaid health plans with information about Medicare assignment broadly, so DSNP, Medicare Advantage, as well as original Medicare information, although they had original Medicare information before, but really beginning to help them link up with managing entities where that was applicable. Phase 2 was then the first phase of encounter information, and that was in October of 2013 with 837I and 837P information, and then Phase 3 brought in the pharmacy information in early 2014. So the Medicare encounter information is newer information for us. We have, since the beginning of our program, like Arizona, required Medicaid encounter data. Also, like Arizona, very much an iterative, evolutionary process in terms of the completeness and the quality of that data, but I think we feel now that we get good encounter data that we certainly use extensively for a number of different purposes.
Okay, next slide, please. Okay, Lori and Patty, could you say a bit about the uses you make of the Medicare Advantage encounter data for care coordination?
Yeah, from the Arizona perspective, as I mentioned, we do have specific contract language that requires our health plans to utilize this data for those variety of uses that you have listed, as well as to identify high-cost, high-need members, and to have a plan for kind of a focused care coordination for those members to ensure that they're getting into services that they should. So look for contraindications on drugs, look at ER utilization, making sure that care placements are transitioned, as you said, in terms of making sure that that whole member is seen and taken care of, and we're looking at both behavioral and physical health in all of those aspects.
This is Patty. So like Arizona, our primary use of the data by the health plans really is for care coordination purposes, again, because a significant number of those members are still not in aligned health plans for Medicare and Medicaid benefits. It gives that Medicaid entity then line of sight into what's happening really with the large bulk of services that that member receives on the primary care and acute care side. Our health plans do a number of things with that data, some of which we prescribe in the contract, and some of which they do sort of above and beyond. I'm going to start with the above and beyond, and then I want to move to the contract requirements specifically. Our health plans use the data for internal risk stratification of the population. Without that information, they would be missing key links in terms of stratifying the population. They use it to look at likelihood of medication non-adherence and to guide individual interventions with members where that could potentially impact their health. They use it in interdisciplinary care team discussions that are really aimed at individualized care planning for members and to really enhance the ability of members and other caregivers to manage chronic conditions. They use the data to identify high-risk conditions, high-risk medications, and again, to intervene from a population health, a chronic condition management perspective, and also to address with members and with physicians the use of high-risk medications that could impact, for example, a member's ability to continue to live safely in the community. In our long-term services and supports programs, care coordinators have access to this information, and again, it helps them from a care planning perspective, both in terms of engaging with that primary care physician and also in terms of managing conditions and managing medication issues. And they do some outreach to physicians who based on interventions that may be needed for members or based on high-risk medications and those sorts of things. One of the things that we've found is that the timeliness of the encounter data, even though we get the encounter data very regularly and we share the encounter data very regularly, it's encounter data, right? And so it's resulting from a claim. And if you're going to use that data for kind of live care coordination purposes, oftentimes it's just not early enough to be effective. So in our contracts, we actually, in addition to receiving encounter data, require our DSNPs and Medicaid plans to exchange information with each other, and they do that on a daily basis. So all hospital admissions, all SNF admissions, all pending discharges, all of those things are communicated on a daily basis between the health plans so that there can be an engagement immediately in discharge planning processes. If individuals will need any sort of long-term services and supports or other Medicaid home health benefits post-discharge, there's an obligation for coordination in the discharge planning process, as well as engagement across both health plans with physicians and other individuals who would be involved in planning for that member's post-discharge.
Patty, just to clarify, when you're talking about two health plans, these would be DSNPs that do not have aligned members, so that their hospital services are provided through one DSNP and their sort of Medicaid services are provided through a Medicaid plan that's not affiliated with that DSNP. Is that correct?
Correct. So we have DSNPs who are not Medicaid health plans at all, and then we have members who are in a DSNP that also operates a companion Medicaid plan, but it's not necessarily aligned, so they have a different health plan. And in that case, that timely exchange of information really facilitates those two plans working together to help plan to address that member's needs.
Okay, thank you. That's very helpful. Let's go to the next set of questions. Okay, the issue of crossover claims is a sticky one because every state in its Medicaid program has a system set up to handle crossover claims in the fee-for-service system, and there are a number of states when they contract with DSNPs agree to pay a fairly small capitated payment to the DSNPs to have them handle the crossover claims, and the providers of the services submit the crossover claims not to the state, but to the DSNP, and the DSNP pays the cost sharing out of that small capitated payment. There are sort of pros and cons of doing this, which we won't go into in great detail, but wanted to get a sense of how both Arizona and Tennessee handle crossover claims in this context, and what role encounter data may play in that process.
Again, on the Arizona side, we do all claims go to the enrolled health plan. So in the respect that they are in a DSNP and it is aligned, the advantage to the provider and the beneficiary is, you know, it's kind of that one-stop shopping. Many of our MCOs have an automated process where they acknowledge that they got the crossover claim and that they will process it under the Medicaid benefit automatically post-processing under the Medicare benefit. And it's just an area we're continuing to look at. The more we get in alignment, the smoother that process seems to be in terms of that processing.
Lori, how long have you been doing that?
Pretty much it's always been in place. I think it works a little bit better with the aligned members. It wasn't quite as well coordinated, you know, between if they were in one access MCO and an unaligned DSNP, which was also another MCO, that coordination wasn't as smooth, but we tried to always facilitate that wherever possible.
Okay. Patty?
So from Tennessee's perspective, we are a little different here than Arizona, and some of this may just be the difference in maturity of the DSNP programs. We still do maintain the crossover claims functions at the state level and do not have our health plans process those. It is certainly something we have contemplated in the past and agree that there would certainly be some efficiencies both from a processing perspective and from the provider's perspective as well. But we do require that all of the DSNPs submit crossover claims for all of the Medicare claims they process to us electronically on behalf of the provider, thereby streamlining that process for the provider as well as for us. So we run those through our claims engine. We pay or deny and send the 835 then directly to the provider. While that may not be as efficient as actually having the health plans process those crossover payments, it at least is a little more seamless to the provider who now doesn't have to submit a paper claim, and certainly more seamless for us because we're getting submissions for those claims from 6 sources rather than paper submissions from thousands of different providers. It is a newer piece for us in terms of requiring the health plans to submit the claims electronically. We've had a couple of bumps in the road with a few of them in terms of not getting all of the information that we require and have worked through some of those or working through some others. And this may turn out to be a step along the path toward eventually having the health plans process those claims, but at this point we're not there yet.
Okay, thank you. Let's go to the next section. So can you say a little bit about, number one, how frequently you get the encounter data from your DSNPs, and you said a little bit about that before, and how does that compare with the frequency in which you get the Medicaid encounter data?
So from the Arizona perspective, we tried as much as possible to have this data be integrated and not really be as separate an effort. So we do get both the MA encounter data and our Medicaid encounter data from our MCOs and DSNPs. They can submit every day. We do process twice a month. And what we found thus far is the timeliness of those two types of data coming to us are fairly consistent. We do have plan sanctions and penalties, but they're specific at this point to the Medicaid data rather than anything having to do with the Medicare DSNP data. And as far as completeness and accuracy, again, we're finding those are pretty consistent. We made a very conscious effort to define those rules consistently, to use those consistent formats, to have appropriate editing in place. And again, I think there's a slide to talk a little bit more about best practices later. And then the place that we've still been working through some of those kind of data consistency things is the Part D, and again, we're making progress with that.
Okay, thank you. Patty?
So from Tennessee's perspective, we require Medicare encounter data and Medicaid encounter data both at a weekly frequency. So we get that information at those same regular intervals. Like Arizona, we have extensive LDs in our contracts with respect to Medicaid encounter data. We don't currently have LDs in the DSNP agreements, primarily because there are no payment contracts, if you will, and so to date we've not opted to put financial sanctions, which means that our leverage really is a contract termination or a no contract extension if there's a significant failure to comply with requirements. In terms of the completeness and accuracy, again, we have the exact same requirements on both sets of data. I mentioned previously that we have had an issue with respect to the electronic crossover claim submissions with not having NPI and tax ID numbers that we need, and in that process had to push a few health plans back to paper claim submission, but have made the renewal of their agreements for 2016 contingent on getting into compliance with those requirements, because that really is the enforcement leverage that we have.
Okay. Patty, and when you were referring to LDs, that's liquidated damages?
Sorry, yes, financial sanctions.
Okay, thank you. Let's go to the next slide. So what kind of resources do you need at the state level to make effective use of the Medicare Advantage encounter data?
So from the Arizona perspective, when we were setting this up, it does require kind of that front-end commitment to get all of the things in place. We took the approach of doing a consortium with a technical consortium with all of our MCOs participating. So it was a very collaborative process, which we kind of found in the end we got better buy-in, it was a better implementation, plus we could leverage some of their resources to help us get to this. So we didn't really add any new or additional staff or contractors to do that. We kind of tried to leverage and make it a project within how we were doing things. The other thing we did was we just looked at a way to use existing system capabilities. So to integrate, again, use those standard formats, make it part of the already existing processes, but to also be thoughtful about how we were going to use this data. So we edited it appropriately, that we kind of defined, where data elements were different between the Medicaid and Medicare data, how we could surmount those differences and still come up with something that we could look at as a whole picture. So we found that collaboration to be really helpful in terms of resourcing this, as well as ultimately the success of putting it in place.
Patty?
And I think Tennessee's approach is very similar. We don't have new or specific staff or resources dedicated to this, but we do have the benefit of a long-standing history of managing Medicaid encounter data and having the resources to be able to do that. And certainly this was a significant project for a number of resources in-house. Our IS staff, as well as our IT contractor, our vendor who operates our MMIS, were heavily engaged in the process of working with the health plans to begin submitting all of the required information. We, like Arizona, have a full medical informatics division that works with our data on an ongoing basis for a number of different analytic purposes, and I think that's really key, especially to the Medicaid agency, being able to use the encounter information. It's also really critical that plans have capacity to manage the data, and that their systems are integrated internal to their health plans, so that care coordinators, for example, who are working really on the Medicaid side of their business, particularly in long-term services and supports or in population health management programs, have access to that data in a timely way to be able to use it effectively for care coordination purposes. And if that's not a part of how those systems operate, it's very difficult to actually be able to use the data in a productive way.
Okay, thank you. Let's go to the next slide. So what's your advice for other states based on your experience so far?
So I think from our perspective in Arizona, kind of being thoughtful about the process, sticking to what you know, standard formats, consistency of data elements where you can, appropriate validation and editing of the data, making it as easy and seamless for your MCOs as possible while still maintaining some identity of the data. We're still able to kind of distinguish, yet they can submit it all together. To actually use the data, we found that once we started using it in our blind spot data, we could see so much more merit of it, and we were able to progress forward with it. Collaborate and engage your MCOs where you can, and to really, you know, some of those things Patty talked about, recognize those differences between the two data sources and find some ways to address those in terms of data elements or editing around that. And then I don't know, Kiana, if you had anything else to add from your perspective.
Well, yes, I do. I mean, I guess one of the things that both Lori and I have touched on is just, I think, that collaborative process. I think when we work together with the MCOs to kind of come up with those solutions, I mean, we're the regulator, but I think having them involved in the discussion is much more productive. And so I would say developing those relationships with the plans has been really useful for Arizona.
From Tennessee's perspective, we agree with everything that Arizona has said. I do think we found that working collaboratively with health plans is really important. Accountability is also an important piece of that, and making sure that the things that you require are in fact a priority for the plans and that they follow through on those contractual requirements is a critical piece as well. We've certainly learned that this is an iterative or evolutionary process and that it takes time and persistence to get to where you want to be. I don't think you're ever done. I think we're always learning about ways to improve the integrity of that data, ways to use the data, better ways even to be able to exchange the data. We think that obviously testing is really, really critical in terms of any implementation, but also realizing that even if you do adequate testing, that some things don't show up until you're in production, and you just have to be prepared to identify those and step back and make corrections. I think that we believe, like Arizona, that really following the formats that you are familiar with and that you use for your Medicaid encounter data makes sense. I think there's a lot of desire sometimes on the part of health plans to give us what they give CMS, and honestly we require more, and we need the more in order to be able to really use the data in a meaningful way. And then finally, it's really critical that health plans are resourced and have capacity to be able to use the data in a meaningful way as well. And that integration of their internal systems really is key, making sure that it's getting all the way down to the frontline staff. You really can use that information to impact the quality of services that are received by a member and to impact individual health outcomes. And that really depends on their having those systems in place to make that work.
Okay. I have one follow-up question before we go to questions from the audience. Back in 2011, when we were interviewing health plans for our Medicaid encounter data primer, we talked to a number of DSNPs and Medicaid plans that did business in multiple states and obviously did business with CMS Medicare Advantage. And what they were saying back then, no surprise, was it really would be nice if all of the states had the same technical specifications for their Medicaid encounter data, and it would really, really, really be nice if CMS Medicare Advantage specifications, which were not out at that point in any detail, were also the same. So we could just kind of submit the same data to everybody. It sounds like that has not quite happened. And Patty, you mentioned that there were some things that you needed to ask the plans to do beyond what they submit to CMS in terms of encounter data to be useful for you. Could you give an example or two of that?
Hang on just a second. I'm going to have Michelle step in on this one.
Okay.
Good afternoon. CMS requires a very minimal amount of information to be supplied to them, submitted to them, and I think they have, by their own acknowledgement, recognized that this does not give them line of sight into what they're paying for and what the utilization looks like across their Medicare membership. And they are actually researching with other states, including Tennessee, other avenues for doing what states like Arizona and Tennessee are doing as far as what we require for submission. I don't know off the top of my head the elements that they require versus the ones that we require, but I believe there are 6 points of encounter data that are the minimal requirements for CMS, and ours is 22. So if that gives you a little bit of context, at least, compared to what we require to be submitted versus what CMS requires today.
And I will say this, right, while I love the notion of standardization, we talk about this a lot, right, across a number of different kinds of topics. The tendency, unfortunately, when we standardize is to standardize to the lowest common denominator, and I don't think that that serves the programs well. So we would be fine with standardizing to the current requirements that we have. I don't think we are comfortable with standardizing to anything less in order to ensure consistency between us and what CMS requires. We've identified what we believe we need to use this information effectively, and we don't want to compromise on that.
Yeah, and I assume the plans grumble a little bit, but do what they're told?
I think that's fair. I mean, I think in particular our Medicaid health plans, they know what we require. And so we don't get a lot of grumbling from our Medicaid health plans when we expect the same thing on the D-SNP side. We sometimes struggle more with D-SNPs who don't operate in the Medicaid program and just aren't familiar with that level of requirement.
Okay. Anne Mary, do we have any questions from the audience?
We don't see any questions that have come in through the Q&A feature as of yet, but we can go ahead and open up the phone lines to see if anyone on the line has a question for Lori, Patty, Kiana, and Michelle.
You are no longer muted.
So we're going to go ahead and unmute the lines and see if anyone has a question to ask.
You are no longer muted.
Okay, so the phone lines are unmuted. Does anyone have a question for any of our panelists today?
This is Elizabeth Wood from New Jersey.
Thanks, Elizabeth. You can go ahead and ask your question.
So I'm curious if any of the states with D-SNP or, if Mathematica is observed anywhere, anyone using a multi-payer database to good effect?
That's a good question. I'm not aware of any, but my colleague Vivian Bird, who's done a lot of work with Medicaid encounter over the years, may be on the phone. Vivian, do you have any thoughts on that question? Seemingly not. We'll see what we can find out and get back to you, Elizabeth, with whatever we're able to find out.
Fantastic, thanks.
Jim, this is Patty. This is an area where I know we've done some work, but I am not going to pretend to be knowledgeable about that work, so I'd be happy to follow up with the folks who are and circle back with you.
Okay, that'd be great.
Okay, do we have any other questions from folks on the line?
I had this is Jim. I had a question for both the Arizona and the Tennessee folks. In your experience, what has been sort of more difficult for plans to do? Is it harder for Medicaid plans to comply with the Medicare Advantage encounter data requirements, or is it harder for the Medicare Advantage plans without much in the way of Medicaid experience to comply with what you're requiring in terms of encounter data? And I'm thinking especially for nursing home services, home and community-based services, other LTSS that they probably are not familiar with at all in Medicare world.
So on the Arizona side, because they're one and the same, because we do require all our MCOs to also be DSNPs, we haven't seen a whole lot of issue in that particular area.
And this is Patty. I think I sort of mentioned this when we were talking about the grumbling conversation. I think it's been a much easier set of expectations for our Medicaid plans who are familiar with the data elements that we require and the processes that we utilize to gather that data. And it's been more of a struggle for the the DSNPs who don't also have a Medicaid contract with us to kind of get up to speed and be able to meet those expectations.
Patty, do you have a sense of how those DSNPs without significant Medicaid experience have actually gone about doing that? I mean, do they hire people with Medicaid experience? Do they sort of have their Medicare people do a crash course on Medicaid LTSS? How do they do it?
Hi, Jim. This is Michelle again. We have seen one of our non-Medicaid contracted DSNPs seek out and employ people that had Medicaid experience. We don't see that is prevalent in all of them, but they don't tend to contract that out. They tend to take it on in-house, and we provided training to them. We also had the MCOs provide, our managed care organizations provide training to the DSNPs, and we had the DSNPs provide trainings to the MCOs so that they could build that capacity within their own organization.
And I think more and more we're seeing, with the dual demonstrations, we're really seeing plans who have in the past operated primarily in the Medicare Advantage world begin to really look at taking on the Medicaid population. And so they are, through various approaches, whether it is purchasing Medicaid insurance companies or whether it is purchasing staff and expertise, really trying to figure that out as they pursue these broader opportunities that require them to be knowledgeable about both sets of benefits.
Mm-hmm. My colleagues, Rivka Weiser and Marcia Gold, just finished a very nice paper for the Kaiser Family Foundation that looked at the Medicare and the Medicaid experience of the plans participating in the dual demos. And one of the questions we had is whether the sort of the DSNPs that operate sort of Medicaid plans as well as DSNPs in multiple states, like Molina and Centene and sort of AmeriGroup and those, whether the way they develop or get the Medicaid experience that they need in a particular state is to draw on the plans and the people that are working in Medicaid in other states, to help them get up to speed. And I wondered if you've seen that be an effective technique, or is it the case that, you've seen one Medicaid program, and that kind of knowledge doesn't cross-fertilize as much as you might expect it to?
So from our perspective, this is Tennessee, I think absolutely it's helpful. And I think those larger multi-state health plans do rely on that expertise. I do think that states in particular, as well as health plans, have to be careful because every program is very different, and the health plan really has to orient to what this state's program is and what this state's expectations are and how they put the infrastructure in place to meet those contractual obligations, which may differ from any other state in which they're operating. I also think, and most of the plans that you mentioned are plans which also have pretty deep long-term services and supports experience, and I think that's a really key piece in all of this. It's one thing to have operated Medicaid managed care, for mothers and children. It's another thing to really have operated it for an ABD population in particular, to have provided long-term services and supports, which is a very different model of care coordination than with the typical Medicaid population.
And this is Kiana from Arizona. Just a quick comment to kind of piggyback on what Patty has just said. I do think in some of our discussions with the health plans, we have found that, they've spoken with their, coworkers in other states, and there's a lot of differences. So I think some of it's mildly useful, some of it's more anecdotal, so we can say, hey, this happened in another state. How can we improve? How can we maybe use some of this to leverage what we're doing? But I think it is, as Patty stated, so distinct in each state based on the contracting requirements, based on the state plan, that I think it is a tricky proposition to assume that Medicaid experience in one state equals Medicaid experience in another state.
Okay, thank you very much. I think we're almost at the end of the hour, so let me switch it back to Anne Mary.
Okay, thank you, Jim. I just want to give folks on the line one last chance to pose a question over the phone. Did anyone else have a question for one of the panelists? Okay, well, thank you all for joining us today. I want to give a huge thank you to Jim and our panelists from Arizona and Tennessee for leading today's presentation and sharing your insights. We really appreciate it. We hope that this study hall call has been useful for folks on the line. If anyone else has questions after you hang up the phone, feel free to email us at integratedcareresourcecenter@chcs.org. We're happy to provide technical assistance and to connect you with the panelists as needed. And Elizabeth, we will follow up with you about your question that you shared with us earlier. So thank you again for joining us today. Thanks to our presenters and our partners at CMS. Have a great rest of the day. Thank you. Bye-bye.
Thank you.
Thank you all.